Can you see? Screen visible?
Gayatri ma'am, we are not audible.
Dyspnea. So what is dyspnea? Dyspnea is usually it will be described as an intense, the feeling of tightness in the chest or air hunger or difficulty in breathing that a person might experience. Okay. Now, this breathlessness is very prevalent, especially in cancer patients and more towards the end of life. Okay, and especially the ones who have thoracic malignancies like lung tumors or esophageal tumors. In them, this breathlessness is very much prevalent. Now, there are some non-medical reasons for breathlessness. Like, for example, if like in healthy individuals, if they undergo or they do strenuous exercises, they might experience some amount of dyspnea. If there is extreme of temperature, either extreme cold or extreme heat, then some amount of difficulty in breathing can be experienced.
Dr.
Also,
Karnik, sorry to interrupt. I think we are facing some disturbance in your voice in between. Is it the same for everyone? Yes. Your response is also coming.
Yes, ma'am. Not able to hear clearly.
It is audible but breaking in between.
now, is it better?
Perfect, ma'am.
Yeah, okay. Sorry for that. Yeah, so we were discussing about the non-medical reasons for dyspnea. So like strenuous exercises or extreme temperature variations or obesity. Then if you go to a higher altitude, like for trekking or something, if you are on a higher altitude, then there the oxygen concentration would be less and people might experience some amount of difficulty in breathing. Also, if there is any particle which gets lodged in the airway, then that can cause difficulty in breathing. Now, that is not a medical reason, but it can be a medical emergency. So that has to be handled that way. Then there are certain medical reasons for dyspnea, like heart failure or low blood pressure, pneumonia, effusion, be it pericardial or pulmonary effusion, then anaphylaxis or stress, okay, or if there is underlying COPD and it gets worsened, then that might lead to dyspnea. Now, why does dyspnea occur? So dyspnea is basically if there is a difficult or if the coordination between the higher center and the afferent signals is disrupted, then that might lead to the dyspnea. Basically, different symptoms, different systems will give different signals to the brain. Like for example, if there is muscle wasting or if there is cachexia in the musculoskeletal system, then that might send some signals to the higher centers, which will which will activate different areas, and that might cause a sensation of breathlessness or increased air hunger. Same way, cardiovascular system and respiratory system, when there are some abnormalities in those systems, there the higher centers get those signals, and then there can be a sense of air hunger or chest tightness that can be experienced. Now, dyspnea in cancer, it is, as we had seen earlier, it is prevalent in cancer. Now, in cancer, what happens, there can be direct effect because of the tumor, there can be indirect effect of the tumor, or that can be related to treatment. So now direct tumor causes can be first is obstruction, like if the tumor is directly obstructing the airways, like you can see in the picture, if there is any thyroid tumor which is enlarged and obstructing the trachea, or tracheal tumors itself, or any esophageal tumor again putting pressure on the trachea, or bronchial tumors or mediastinal lymphadenopathy. So all these things which are putting pressure or obstructing the airways in some or the other way, that can cause dyspnea. Then there can be pleural effusion or pericardial effusion because of the tumor. Then tumors can be large enough to obstruct the superior vena cava here, and that again might lead to dyspnea or shortness of breath. If there is ascites in the abdominal cavity, that will push the diaphragm further up, and that can cause this thing. And ascites can be because of presence of tumor in the abdominal cavity, or hepatomegaly or tumor emboli. So all these reasons can be directly because of the presence of tumor in the body. Now, indirect causes is, for example, cancer can cause cachexia, cancer can cause electrolyte imbalances, or there can be some infection or anemia. So because of all these reasons also, there can be dyspnea that the patient might experience. Now, treatment related causes, for example, if the person is undergoing a surgery for lung tumor or thoracic tumor, so then there will be a scar on the thoracic wall, that is a chest wall. So that will reduce the chest expansion. Or if there is any abdominal surgery, that is a laparotomy or something, and in some cases the diaphragm is also handled during the surgery. So in such cases the diaphragmatic excursion would be less. So that again would lead to some breathing difficulties. If the patient is undergoing radiation to the chest wall, say for example, the breast cancer patients or lung patients, thoracic, esophageal patients. So those patients who have undergone radiation might develop radiation pneumonitis or fibrosis of the lung parenchyma. Then some chemotherapy drugs are known to cause fibrosis, like bleomycin will cause pulmonary fibrosis, adriamycin will cause cardiomyopathy. All these things, complications of chemotherapy drugs might lead to breathlessness indirectly. Also, people like patients undergoing chemotherapy might have neutropenia or underlying infection, which might again lead to breathlessness. Now, as we know, there are different grades of dyspnea. So this one is the Medical Research Council grades. Then for assessment, now breathlessness again is a subjective experience. So different patients will have different experience of breathlessness, and they will grade it according to their subjective this thing. So if the patient is coming on an OPD basis or in a emergency service, the physician would first assess the ABC, that is the airway, breathing and circulation, to first see if the patient requires any emergency care or no. If the emergency care is required, then obviously stabilizing the patient will be the first thing, and then the series of scans or tests or things would follow. Then when we are seeing as physiotherapists, when we want to check a patient, we would first we have to observe for the use of accessory muscles or the speaking ability of the patient, like how many words can he speak in one breath, or he is frequently stopping, he can speak very few words. Okay, so those things have to be observed. Also along with that, we have to check for the presence of lower limb edema, because bilateral edema might suggest an underlying cardiac cause probably, or the presence of cyanosis or clubbing. So all these things have to be observed. Then on palpation, we can come to know about the presence of subcutaneous emphysema or any crepitus, palpable crepitus if it is there. Percussion will help us to know if there is any consolidation or effusion. Then if there is hyperresonance, then it can be due to pneumothorax. And on auscultation, again, we will come to know a lot of things. So all these things are important in assessing a patient. Now, before going to management, there are certain things which can be done to prevent dyspnea. So the most important in healthy individuals is to quit smoking. The ones who are used to smoking can quit smoking, so that the lungs can remain in a healthy condition. Okay. The other steps are, first is treating underlying conditions. So majorly we'll see that to treat dyspnea, the underlying condition which is causing dyspnea has to be addressed first. Okay. Now in certain individuals, there might be like they might be aware that they have some cardiac or pulmonary or any other thing which is just starting to show up, but they might decide to not pay attention to it or just ignore it. And later on, those things might just become more aggressive and cause various problems, including dyspnea as one of it. So if those underlying conditions are addressed in the initial phases, then further problems can be prevented. Avoiding air pollution. Now, this in today's age is not completely possible, But what can be done is using protective gears, like using mask. So we are using mask nowadays for virus, but that mask is also preventing a lot of other things, like preventing a lot of air pollution from entering our lungs. Okay. Now there are certain industries or certain workplaces where there is a lot of smoke or chemical fumes which are generated. So such areas, if they are well ventilated, then the workers would be, lesser amount of air pollution would enter into their, like would cause some effect on them. Also, maintaining a moderate weight, like if there is any person who's overweight or obese, then they have to reduce their like they have to concentrate more on reducing their weight, so that all the problems which obesity causes can be prevented, and dyspnea is also one of them. Avoiding overexertion. Now, suddenly somebody realizes that they have to lose weight, and then they start intense exercises, or they have a target, like in 1 month, maybe I have a convocation, or a friend is getting married, or whatever reason. And they suddenly decide to lose weight, and then they will just push themselves. So that also will be one of the reasons where they are just getting out of breath, but still, because they want to lose weight, they will go beyond their limits. So that is not a right way of exercising also. And to prevent difficulty in breathing, that overexertion, unnecessary overexertion can be avoided. Now, in management, again, the first foremost thing is to treat the underlying cause, like congestive heart failure or infection or embolism or effusion or whatever it is. So just treat that, and that will automatically take care of dyspnea to a certain level. Now, pain is also one of the factors. Now, pain, for example, even if it is a post-operative pain. So, as physiotherapists, when we see the patient on post-op day 1, when we want the patient to do, say, spirometer. So they might not be able to do it that well if they are in severe pain, right? Once you take care of the pain, automatically the inspiration will improve, and the performance will be better. So pain is one of the main reasons which leads to dyspnea as well. Then there are certain non-pharmacological interventions, like using a fan or airflow on the face. Now, the exact mechanism is not known how it helps in reducing the dyspnea, but there are a lot of studies which have been done, which show, like some of them show that it does reduce dyspnea, and some of them are not so conclusive. But a lot of physicians do recommend the use of fan, because it has no side effects per se. Okay, and it's very easy, a small handheld device, battery operated, not so expensive also. So it can be easily given to the patient, so that they can use it to reduce their breathing problem. Also, sometimes the use of mobility aids will help in improving breathlessness, because it will help in reducing the energy expenditure that a patient has. So, for example, if you give a rollator, so by the use of rollator, the patients will have ease in walking. Also, it has a seat, so whenever the patient is tired, he or she can just sit down for a break, and then again get up and start walking. So rollators have shown to have a lot of effect in reducing dyspnea. Also, as your upper limb is fixed, so it will also reduce the use of accessory muscles. Then there are different positions which will help in reducing dyspnea, like for example, high side lying. So either with the use of multiple pillows, or if there is a hospital bed, so just propping up the bed. So these things will help in reducing dyspnea, or sitting upright, or leaning against a table, leaning against a wall. There are various positions, and for different patients, different positions might work. So then these positions should be, like the patient should be made aware about all these positions. So whichever position is comfortable for the patient, he or she can use it when they have those bouts of breathlessness. Now, coming to physiotherapy management, so when the underlying cause has been taken care of, and the patient comes to us for the further management, So we can use all the different modalities that we have, like aerobic exercise, resistance exercises, thoracic expansion exercises, breathing, diaphragmatic breathing. So all these things have shown to have good results on improving the lung condition of the patient. Also, while we are seeing these patients, we have to continuously monitor them, which is very important. And also supplemental oxygen has to be kept handy so that just in case if the patient requires it, we don't have to run here and there at the last moment. Then breathing retraining. Now, as we know that dyspnea, if a patient has prolonged dyspnea, then they might start using their accessory muscles, or in post-operative patients, the diaphragmatic recruitment might not be, diaphragmatic excursion might not be that good. So in all these cases, there are various techniques which we have studied, which will help in improving say the reducing the use of accessory muscles or improving the diaphragmatic excursion. So diaphragmatic breathing exercises or post-sleep breathing or breathing control, like time the breathing, ask the patient to inspire for a certain seconds and exhalation to be done for a certain seconds. So such kind of breathing control will also help in reducing the dyspnea. Now, let's see what happens in palliative care. Now, what is palliative care? Palliative care is when there is no specific treatment for the disease that is available, but mainly the focus will be on symptomatic management. The disease is spread so much that definitive treatment might not be of any help. So in palliative patients, dyspnea is a very common symptom, especially towards the end of life. So almost 70% of the patients in the last 4 to 6 weeks of their lives will definitely experience dyspnea. Now, in palliative patients, there will be two types of interventions. Basically, one will be little non-specific and one will be disease-specific. But some measures which are used in all the patient will be reassurance, because usually because of the treatment that the patient is undergoing or the disease state, the patient might already be very anxious about the future, and suddenly when there are bouts of dyspnea, the anxiety might just increase. So reassuring the patient is very important. Okay, positioning the patient in whatever position is comfortable for him, making sure that the room in which the patient is well ventilated, that is important, and the fan, blowing of the fan on the face can be used. Now, non-specific interventions would include use of supplemental oxygen or use of opioids or benzodiazepines, which will put the patient to sleep, so that even sleep has shown to reduce the difficulty. So that can be used. Then again, in palliative patients also, it will be treat the underlying cause. But here the thing is, if it is possible and if it is appropriate. Because as I mentioned, in palliative patients, there is no specific treatment that is there. So basically the pros and cons of whatever treatment you're planning has to be decided. Say for example, if the patient has very less time left, and if you want him to undergo a major surgery, then it's not going to be of any use for the patient per se. In fact, it's going to add to the trouble by adding up the pain of surgery and all other complications. So in that case, it's better to avoid surgery. So same way, whatever treatment has to be given, the pros and cons have to be evaluated first, and then it has to be decided what is better for the patient. So some of the disease-specific medications would include, say, corticosteroids, or like to reduce inflammation, or diuretics, or antibiotics, whatever is the underlying cause. So depending on that, different medications can be used. Now, in the final hours, what happens is when the patient is on the deathbed, there is something called as death rattle, which is very prominent. What is a death rattle? So it is a sound, like a gurgling sound that can be heard, which is because of the accumulation of secretions in the throat or the mouth, and the patient is not able to either swallow it or take it out of the mouth. So the secretions have accumulated, and when the air is passing through the nose or the mouth, there is this gurgling sound which is there. So what can be done for that is positioning. So if the patient is comfortable, just turning the patient to one side so that the secretions automatically come out, or using some anti-secretory agents if required. Now, if the secretions are not working on these things, then suctioning can be considered as a last option, because at this stage of the patient's life, we don't want any invasive techniques to be used, to disturb the patient even furthermore. So if the secretions are too distressing for the patient, or if it is accessible to be cleared easily without going deep into the throat, then it would be recommended. Otherwise, no. So these are the things which are to be considered during the final hours of critically ill patient. So that's it. Any doubts, any questions?
Thank you, Dr. Gayatri, for that wonderful session. Now the forum is open to audience. You can bring in your points, queries, questions, if any, before we move on to the case presentation. We hope that there are no inputs or queries from the audience. In that case, Dr. Gayatri, with your permission, can we move on to the case presentation?
Yeah, sure.
Okay. Fatima, ma'am, over to you.
Can I?
Sure, please go ahead.
Hi, I'm Fatima. Thank you, Gayatri ma'am, such an elaborate explanation on dyspnea. Okay, I'm going with the presentation. Actually, it's an 88-year-old male who is a retired professor and was diagnosed with COVID pneumonia. His presenting complaints were absolutely breathing difficulty, unable to do his ADL, and unable to change the positions without support, fatigue, increased effort of breathing, there was use of accessory muscles, and tremor, bradykinesia, depression, anxiety, and lack of sleep. When it comes to history of illness, he is a patient with non-case of Parkinsonism, but he independently did his whole ADL, even though having all the symptoms of disease. Okay, he was tested COVID positive with symptoms and was on medication. And later he was diagnosed with pneumonia. 2 liters of oxygen was administered to him as his SpO2 was dropping. Gradually, the continuous use of O2 stopped, but his SpO2 was still dropping for minimum effort he used. Okay. Okay. When on examination, conscious and oriented, and his BP was 135/75 and SpO2 was 96. When it comes to passive range of motion, upper limb and lower limb was in full range of motion, and active range of motion was also in normal range. MMP was grade 3 for both limbs. According to modified Borg scale dyspnea, he was in grade 7. I put the Borg scale dyspnea for your reference. And when it comes to auscultative percussion, the dull thuds were heard and presence of wheezing was there and lack of breathing sounds in certain area. When it comes to investigation, the CT scan of lungs shows multifocal areas of ground glass opacities with interstitial thickening in bilateral lung parenchyma, more in the peripheral and basal segments. And there was patchy areas of consolidations in bilateral upper lobes, fibrolactic changes and early traction bronchiectasis in bilateral posterior basal segment. This was the features are suggestive of COVID pneumonia. When it comes to physiotherapy intervention, our aim was to make the patient able to stand, sit, and change the positions by himself, able to do his ADL independently, and not to make him bedbound. When it comes to our plan, educate the patient and family about the situation and breathing exercises, energy conservation techniques, and assisted active range of motion techniques and fall prevention techniques, as he was told earlier. When it comes to methods, the breathing exercise include the diaphragmatic breathing, the pursed lip breathing, square breathing, 478 breathing, and I forgot to add the spirometry also, along with chest clearance techniques. And I use this is I don't use the both all techniques together. We switch the techniques. Okay, and we also use convenient positioning, or the positioning is also a subjective method. For this patient, high side lying was a convenient positioning, and sitting upright in a chair with supporting arms, and sitting leaning forward from the waist, arm resting on the pillows and tables on the floor. And when standing relaxed, when we were walking, when he become irritated, we will standing relaxed, leaning forwards with arm resting on a support on a window, or standing leaning back against a wall with legs slightly apart. And when it comes to exercises, there was a active range of motion exercises for upper limb and lower limb, and a small overhead hand movements, light stretch for neck and trunk muscles, and resistance exercises with low loads or with manual resistance. Just sit to stand exercises and just walking in the room. And the progresses was assessed by 6-minute walk test. And fall prevention strategies, like we give him an assistive devices like walker. And when it comes to the psychological aspect, he's a retired professor and have his wife and 2 sons with him to look after, and financially there was no struggle. His concern was that he don't want to be dependent for his basic needs, and there was a fear of death too. He was always a moody and not interested in any activities. He was in a sort of a depression mode. This was the medication he was taking. And when it comes to the, can I skip to the next page? Okay, when his main concern was physically the difficulty of breathing, he was very fatigued and unable to do his ATL and lack of sleep. Psychologically too, the depression, anxiety, and lack of sleep. And when coming to socioeconomic case, he was economically balanced and there was a supportive family. When it comes to spiritual, there was a fear of death. When it comes to summary, he is an 88-year-old male patient with history of Parkinsonism and was diagnosed with COVID pneumonia. Even though he was having all the symptoms of Parkinsonism, he managed to do all of his activities. Okay, then he got COVID infection and led to pneumonia. And later there was a severe breathing difficulty which impedes his activities. He had his wife and children for emotional support, but he was always in a depressed mode. After a few sessions of physical therapy, his condition became better. His both dyspnea score decreases to 3, but even when he took an extra offload, it will make him breathless. When it comes to the discussion point, our main problem was that he was so aged. He was 88 years old. So a complete back to normal life is possible in this stage. That was one of the query we had. And his state of mind, even though there is a progress in his depression, he was not encouraged to do the exercises. And I was not working in a palliative care. I was working in a hospital. So this treatment was did in a hospital. I think there will be a change in his state of mind when he discharged from the hospital, or there was a limitation for us to do it in a hospital setting.
Thank you, Fatima, for bringing in that very relevant case presentation. Now, before moving on to Dr. Gayatri, the discussion points are now open to the other participants. Your inputs. Suppose this patient had come to your setting or come to your consultation. What would be your points? What would be your considerations for this particular patient? You can either unmute and say, or you can put in your suggestions in the chat box. would request active participation from the participants, because otherwise there would be no point in bringing in such cases, because cases are meant to be a mutual learning for everyone. So we would humbly request the participants. And one more thing we would like to remind here is that there is nothing wrong and nothing right. Only when you speak up what you feel is appropriate, then only will we do learn mutually.
There is one thing which I want to ask.
Okay.
You said the progress was assessed with the 6-minute walk test. So
Yeah.
with a box scale of 7, like how much, like when did you first assess the 6-minute, and like how much was he able to perform in the beginning?
In the beginning, he was not much performed the 6-minute walk test. He can't walk at 2 steps.
Mhm.
Actually, the 6-minute was like, can I just a minute? Actually, he couldn't complete the 6-minute walk test, 6 minute in the walk test, but there was a progression. He was taking an
You are
he
muted.
was taking an hello.
No, no, you were
Hello?
muted.
Okay, I'm sorry. Actually, for the first days of the treatment, he couldn't complete the 6-minute walk test. And later on, he couldn't complete the 6-minute walk test, but there was a progression. He could walk at 4 minutes. And I know it's just not a 6-minute walk test, but we always use the 6-minute walk test for the progression, for making the assessment in progression. The main thing was, the main tool was used for the Dyspnea scale.
And how many days did you see him in the hospital?
2 weeks.
2 weeks. Okay.
Yeah.
So
He
activity
was in
wise, how
ICU.
much?
He was in
Go
ICU.
ahead, go ahead.
Okay, sorry.
Okay.
Okay. Okay.
So
ask-
activity wise, how much was the difference? Like what was his activity
Okay.
level in the beginning?
When we do the active range of motions, he was very unwilling to do first, but when we encouraged him to, he can do that one.
Okay.
But on the first initial stage, even though he was doing a active range of motion, all exercise, he was being very irritated, and it was in breathing difficulty. But later on, he could do the activities, even though it's taking a lot of time, but he could complete the activities.
And how much was the oxygen level that he was on? How many liters of oxygen was he on?
2 liters of oxygen.
Okay. So was it the same till the end, or did it?
Yeah, actually, till the end, he wasn't using oxygen continuously. But when he
Okay.
doing the any activities for an strenuous activities, he become breathlessness, and again we administer the 2 liter of oxygen.
Okay.
Can you just explain the second point? What exactly is your concern?
Actually, his state of mind, even though he was very depressed. Okay, when there is a progress in depression when from the earlier days, he was so depressed, but there was a progression in depression. He was talking to his relatives and to us also, but he was not that much encouraged to do the exercises.
So this progress in depression, like how was it monitored, or how was it?
Yeah, was it clinical depression?
Actually, it was not it was a subjective one. We just he was not interested to us, or he wasn't talking to the relatives for the first stages, and then he become talkative to the relatives and also to us. He was just in a mode of anxiety and depression. That was not, I think, a clinical depression.
So was there any counseling going on for him
Yeah, he
by a
was
professional?
having. Yeah, the psychological team was having talk with him, and I think in medications also he was having medicines for the anxiety and depression.
Yeah, so for the first point, that is the age related, like considering his age and considering his Parkinson's also, it might not be possible for him to get back completely to the normal life. Some amount of this thing might be there.
Okay.
And for this depression and all, it would be better if if he continues to undergo his counseling sessions. That
Okay.
might help. Any follow up after that? Like, did he come for a follow up to the hospital or?
No, ma'am, we couldn't get the follow-up. He was
Okay.
discharged.
Okay.
Good evening, Fatima. I had a question for you.
Okay.
It was easy for you to use modified Dyspnea scale,
Okay.
but you didn't use it, and the patient was in ICU. And how it is possible for you to use a 6 minutes box scale?
No, we weren't using 6 minute walk test in ICU. Actually, I said we usually use the dyspnea scale for the 6 minute walk test for the dyspnea patient. But it was not a complete success for this case. After he was shifting to the room, we just used the 6 minute walk test, and for the first time he couldn't complete that one. But later on, he could complete a small distance in this term, but that was not a 6 minute one.
Yeah. So instead of a 6 minute, it could be like a 2 minute test or something like that. You can monitor
Yes,
how
yeah,
much
yeah.
you are
That's like.
walking.
Any other comments?
Just wanted to make sure from Dr. Gayatri, usually in COVID or in post-COVID pneumonia, prone lying was the better position to comfort the patient to relieve his dyspnea.
Yes.
Yeah, so
It was suggested by many of the articles during the COVID. So it will be better.
just wanted to confirm, does it depend upon the reason or like the reasoning for dyspnea, or in generalized it is given?
Yeah, in general also, like before COVID also, there were like some patients in ICU which we used to see, if they are not maintaining their saturation or something, a prone position would be preferred for them, because that is said to like help in excursion of the lungs in a better way, as it does not, like the diaphragm is not obstructed by the abdominal contents, so
Right.
that is a better position.
Okay, thank you.
Hi, ma'am. It's Anupama here. I think in most of the hospitals, they used to lift the patient upright in almost 30 to 40 degrees so that it's easy for the patient to breathe properly without much exertion to the muscles and the diaphragm. So I think many of the hospitals are using that method, and they are giving O2 support if needed. And if the patient is having any other obstruction or any other secretions, they will change the direction half between 1 to 2 hours gap. like that.
Yeah, so prone position will not be used for every patient, but especially the
Yeah.
ones who are not maintaining the saturation, for them, that would be preferred.
Yeah, thank you.
Any other questions?
If no one else has any comments or suggestions, Dr. Gayatri, over to you for the closing remarks on this particular case. If anything more to add.
No, I asked whatever doubts I had, and it was a good presentation. Only if the follow-up would have been there, then that would have been better. So we would have understood how the patient is progressing post-discharge.
Any other, like not pertaining to the case, but to the topic? Does anyone have any queries?
Am I audible, ma'am?
Yes,
Yes.
Dr. Vandana.
Yeah. Actually, I would like to add something more in the positioning part of the patient. Like usually it is seen or it is recommended like prone position needs to be given to the dyspneic patient, but it is not always so. Yes, sometimes clinically it has been seen that it helps in improving the V by Q mismatch or improves the oxygenation. But in case of like in COVID or in any such cases which are critically ill and in ICU and in the patient is intubated or in oxygen therapy, then care needs to be taken. We should monitor the vitals first, then only we should go for providing any kind of positioning, because it has been seen like even in COVID patient, it has been seen that while turning the patient like from supine to sideline also, the saturation or the heart rate or the respiratory rate there, the changes gets to occur very quickly. Like the patient starts to get tachycardia or the saturation starts to drop down. So clinically, we have to have a judgment before providing the prone position directly to the patient, and we should actually try to first make the patient to come to quarter turn supine and then gradually sideline and then prone, rather than going directly from supine to prone. We should try in this manner if we actually want to give positioning to the patient.
Yes, that is true for anything. Obviously, if the patient's vitals are not stable, then you have to gradually progress.
Thank you, Dr. Vandana, for sharing that valuable information. Anybody else would like to add?
Hi, ma'am. There, I would like to add something. If the patient, suppose the patient is in ICU and the patient is suffering from post-COVID illness, or even if the patient is having COVID illness, we should actually check the X-ray first, and then we have to check the vitals. After that, we have to score the patient under whichever score we are using for the ICU method, and after that, we should actually consult the pulmonologist and ask if the doctor should do any extra medications or give any uh, like no, no, any inhalers or any other O2 or etc. Or like that. and we should add on to our question that whether we should do a chest physio, or we should give a spiro, or we should teach him a small breathing exercise so that the capacity of the lung get increased. So I think most of the physiotherapists here does not usually take a score when the patient is in ICU. They just go visit the patient, talk to them, and just leave like that. So, ma'am, would you like to add on something for the for everyone in this session?
By scoring, like what score are you talking about?
Ma'am, the dyspnea score.
The Dyspnea score. Yeah. So it's always better, obviously, to do a thorough assessment of the patient, to know the previous history, medical history, and then the current status of the vitals of the patient, and then progress with our treatment. So it won't be always same for everybody. It will differ from patient to patient.
If no one has anything else more to add, I think we have reached the end of today's session. So, Dr. Gayatri, thank you so much for joining us again for this wonderful session. I believe this was really informative for everyone as usual. And we do know your busy schedule, and still you found out time for this cohort. Thank you so much for that. And thank you all the participants for joining in. And along with that, note, this is Sri Priya along with Mr. Vaishnav and Dr. Gayatri signing off from the Tips Eco Hub. See you in the next session with another interesting topic and another eminent faculty. Till then, everyone, stay safe, be happy, spread happiness.
Thank you.
Take care. Bye-bye.
Thank you.